Assalamu alaikum wa rahmatullahi ta'ala wa barakatuh. Welcome to our center, Excellence in Clinical Pharmacy Practice, and welcome to our today's, let's say, workshop or small lecture, small informative lecture about high alert medication. This presentation has been prepared and will be presented by me, Sahar Mamoon. I am a board certified pharmacotherapy specialist, as well as board certified cardiology specialist. I have got a master in business administration. I am certified trainer. I have a TOT from Oxford University, as well as I acquired my master in clinical pharmacy from University College London in the UK. Inshallah, today, together in this small presentation, we are going to know, we will know what are high alert medications, why they are called high alert medications, what are the examples of medication we encounter on our daily practice, which are categorized as high alert medications, okay? And we will also touch on what are the high risk or what are the risk factors which makes handling or which makes any error discovered by high alert medication is bothersome. And then finally, we will be touching on how to handle high alert medication. Me as a pharmacist in the ward, while I am working, how can I handle such medications in the process of the medication process itself, starting by the storage and labeling, and then the prescribing, and then the preparation and dispensing, and finally the administration of these medication. Okay, so high alert medications, what are they? High alert medications are medication which hold a heightened risk, okay? Heightened risk of what? Of causing significant patient harm when they are used in error. It doesn't mean that if I always use high alert medication, it will cause harm. No, we said when it is used in error, whatever the stage of the error itself, okay? So although mistakes may or may not be more common with these drugs, like that is not what I am after. What I am after is that the consequences of an error is clearly devastating, it's clearly marked, okay? And that's why we have to handle such medications in a specific way. What are examples? Me as a pharmacist, I have to know that there are some medications related to certain classes that are high alert medication. This list is not inclusive, okay? Because it depends on what? It depends on the formulary of the hospital or the healthcare institute you are working in, okay? For example, we will find that in some hospitals, some tertiary hospitals, anticoagulants are in the formulary, whereas in another small medical center, okay, or secondary healthcare institute, that anticoagulants are not there. So it depends on the medications which are in the formulary. From my practice and from where I used to be formally working, these are the list of high alert medications. Number one, we have got the concentrated electrolytes. The concentrated electrolytes are electrolytes which have high concentration, okay, such as calcium chloride, calcium gluconate, magnesium sulfate, potassium chloride, okay, and potassium chloride, we know that it comes in 20 millimole or higher. So from 20 millimole per ml, it is a high alert medication. And then sodium chloride 3%, which is the hypertonic saline. The hypertonic saline, which is used for increased secretions, okay, or the congestion in the respiratory tract. So we use it as a nebulization form. And in this form, it is considered as high alert medication. And then sodium bicarbonate, which is used in cases of emergencies where there is an acid-base imbalance. Secondly, we have got concentrated dextrose in concentration of 20% or more, whether it is dextrose 50% vials, which is already prepared by manufacturer, or if you are to prepare any concentration of a dextrose, which is 20% or more. And then we have got third class of agent is adrenergic agonists, which are an intravenous, okay, and here we encounter these medications not only as high alert medication, but they are also called look-alike and sound-alike medication. Look-alike and sound-alike medications are medications which also poses increased risk, okay, when they are used in error. Why? Because either they sound alike, okay, or in their packaging they look alike. The manufacturer is, for example, manufacturing epinephrine and norepinephrine, or dopamine, dobutamine. So the packaging, we find it to be similarly, which can cause dispensing error, okay, and so on. So adrenergic agonists are not only high alert medication that should be, we should take care while we're dealing with them, but also some of them are look-alike and sound-alike medications. So, as we said, the class is adrenergic agonists, which are used intravenously. Okay, and we said that this is not only because they have a high alert that they may cause a heightened risk when used in error, but also we can have another type of error which is related to confusing between these agents. Why? Because they look alike or they sound alike. In another, inshallah, workshop, we can talk about the look-alike or sound-alike. But in summary, look-alike, sound-alike are medications which are visually similar, okay, in their packaging, all right? Or they are the name of the medications, when we spell them, they have got certain similarities, such as dopamine, dobutamine. The third class of agent is anesthetic agents, etomidate. Etomidate is a hypnotic anesthetic agent, okay, which is also considered a high alert medication. Again, I'm just reminding that these medications are the medications per the hospital, okay. You may go and search on Google about high alert medication, for example, according to the ISMP, the Institute of Safe Medication Practice, and you will find another medications. It doesn't mean that it is different, but it depends on the availability of the medication in the hospital. Antiarrhythmic, especially the intravenous, okay, they are considered high alert medication, such as procainamide, lidocaine, amiodarone, verapamil, and adenosine. One of the popular classes of medications which are considered high alert medication due to their nature of causing bleeding is the antithrombotic or the anticoagulant agent. So we know that these medications, some of them such as warfarin, are considered a high, they are considered narrow index medication. Why? Because the difference between the minimum, the maximum concentration and the minimum concentration is very narrow. Okay, and that's why they are considered narrow. Warfarin is considered narrow therapeutic index medication. So anticoagulant, the oral form, we have warfarin. We have got the heparines, the two types of heparin, unfractionated heparin and low molecular weight heparin. And then we have got the newer direct oral anticoagulant agents, such as factor 10A inhibitors, and that include abexapan and rivaroxapan and fondaparinux, and then direct thrombin inhibitors such as dabigatran and thrombolytic agents alteplase and tinctiplase. For sure, we know that these medications are used in patients who are predisposed to clots, okay, such as atrial fibrillation patients and patients who have got valve problems, whether these valves are impaired or they have been replaced. So we need these agents. And On the other side, we need the thrombolytic agents. We know that we need it in the acute coronary syndrome when the patient is admitted to the ER with a myocardial infarction, and sometimes also in unstable angina, we use them. Okay, so and then another classes of agents which is available in any tertiary hospital or long-term rehabilitation hospital is narcotics. Okay, narcotics such as morphine, fentanyl, and then opioids such as tramadol. All of these are considered high alert medication. Neuromuscular blocking agents, which are used in surgeries, such as whether it is a depolarizing or non-depolarizing blocking agent. Succinylcholine is the depolarizing, non-depolarizing is cystocurium and roricronium and so on. And then we have got medications which cause sedation when used intravenously, and that is midazolam, lorazepam, and diazepam. Oral hypoglycemic agents. If you remember, we said that concentrated dextrose, when giving sugar in high concentration, is a high alert medications, and oral hypoglycemic such as metformin, biguanides, and then the sulfonylurea, gliclazide, and then ripaglinide, and then sitagliptin, linagliptin, and empagliflozin. Finally, and then we include also insulins. Insulins are very dangerous because we have got a variety of insulin preparation, and these insulin preparation, they do differ in their what? They do differ in their the onset of action, okay, how long it takes for them to work, and at the same time for the duration of action, okay, for the duration of action. So we know that lisproaspart, regular insulin, these are short acting, and they act for short duration of action, whereas insulin glargine and ditamir, they work for almost 24 hours. So it's very important when you are dealing with insulin preparation in the ward to make sure you are counter-checking what you are dispensing and the label is correct and so on, as we will come to know. And that is why, that is because due to the product variation within this class of agents, the insulin. So this is all the examples of high alert medications. By practice, if you are newly if you have newly entered into the practice, you by repeating them, or by repetition in the daily practice, you will come to know that you have already memorized them. Okay, so what are the risk factors? What are the factors which makes high alert medications dangerous, or what are the factors which contribute to this medication if they are used in error to cause heightened risk? Okay, so we have got different types of risk. We have got different categories of risk factors. Number one, we talked about mainly, if you remember, we talked about medications which are used mostly in the intravenous dosage form. Okay, so concentrated electrolyte as injectables, adrenergic agonist as an IV, anesthetic agents IV, antiarrhythmic IV, and so on. So this will contribute to that. There will be a variable mistakes which can occur during the preparation, or during the preparation of such agent, and during the administration. For example, you can, from the beginning, it can be confused that what are the certain route of administration for certain agent. Is it intravenous? Is it intramuscular? Is it intrathecal, or what is it? The second thing is that when these medications, they are used as infusions, you may encounter, or there will be a high possibility of error while calculating, for example, the infusion rate. Okay, and then also when you are preparing medications, are you choosing the correct diluent? Okay, are you using the correct dose or strength of the drug, or are you, and so on. So for example, if a patient is hypotensive, okay, and he needs noradrenaline, okay, and he needs it as soon as possible, and at the same time this patient is hypoglycemic. So in this situation, what are you going to do? You are going to dissolve for example, 4 or 8 milligram of noradrenaline in specific concentration of the dextrose. So it depends on the physician, what he chooses, but at the end of the day, from our side as a pharmacist, we have to make sure that there is a compatibility between the solute. Here it is it's a liquid, which is noradrenaline, between the solute and the solvent. The solvent, what is it? What is the concentration of the dextrose this patient needs? It depends on the blood glucose trend and the blood glucose trend over the last period of time. So here in the preparation of such agents also we have to be careful, and I talked already about the look-alike and sound-alike medications, which are, these medications are visually, they look similar, or visually similar because of the packaging, or they have got similarities in the spelling. Also, there is another problems, especially with the insulin, while you are interpreting the order. If you are interpreting the order, we know that certain abbreviations, it shouldn't be, it is for sure not to be used. For example, while using the U for units, okay, you want to write units, and then, for example, 10 units of glargine, okay? When you write it as a U, this can be misinterpreted, okay? And that may lead to mistakes, all right? And also using the trailing zero. The trailing zero is, for example, when I want to write three units of insulin, I will write it 3.0, which will also increase the risk of error, because it will be interpreted, sometimes it can be interpreted as 30 instead of 3. So that is the trailing zero. Another thing also with insulin is the availability of product variation. We have got insulin regular, insulin aspart, insulin glycerin, and so on. So there is a confusion of the different strings, the multiple formulations, multiple brands, and the color of such medication. And lastly is ambiguous labeling, when there is an unclear concentration, an unclear total volume information on the container or into the bag of the electrolyte. All of these, they contribute to the increasing the risk of using high alert medications. So we have to be aware about them. Okay, so how can I handle high alert medications? As we said, these medications, they need a special safeguard, okay, in order to reduce the risk of error. Okay, this may include, you have to make sure that there is enough accessible information about these drugs for all healthcare providers. For me as a pharmacist, for the nurses who are using such medication in the wards, for even the nurses who have, in some institutes, they have access to the pharmacy in out of pharmacy hours, and so on. So you have to have improved access to information in the policies, in the guidelines, which is related to such medication. And then we have to limit the availability of high alert medication as much as we can. We have to limit it to where? We have to limit it to places where it is clinically necessary to have it, okay? For example, what are the medications which are to be included in the crash cart? We know that this crash cart is the crash cart which is opened, or are the list of medications which are necessary when we are resuscitating a patient, okay? For example, we need adrenaline, we need sodium bicarbonate, we need amiodarone, we need atropine. All of these are medication, we say emergency medication. So limiting access of high alert medication, for example, I have to make sure that I have got phytomenedione, for example, vitamin K, okay, in case the patient is bleeding in the crash cart. For example, sodium bicarbonate, and so on, okay? So it has to be in a places where it is clinically necessary. For example, concentrated electrolytes, there is no need to leave concentrated electrolytes in the wards, okay? It has to be limited to certain areas in close locked cupboards. Using auxiliary labels and automated alerts, we have to make our labels look very, for example, the labels has to be complete. It has to be thorough. It has to have the name of the medication, the strengths of the medication, if it is to be used as an infusion rate, what is the rate, and then what is the preparation time of such medication, what is the expiry of the such medication, and so on. So it has to be complete labels. Standardize, standardize, standardize. The more you standardize the process of handling high alert medication, the less error you are making. And that is a key point you have to take from our today's presentation. When you standardize the procedure of ordering such medication, storing, preparation, and administration of these products, when you standardize it, the more you standardize, the less error you have. And then you have to employ redundancies such as independent double check, as we will come to see. So let's start from the storage labeling stage. How can I handle high alert medication? This is the containers, okay, in which you can store high alert medication, and this is the labels which has to be attached. We will speak later about where these high alert labels should be placed. So high alert medication storage, it is limited to the pharmacy and to those specific areas that are deemed clinically necessary. There should be a designated storage for high alert medication. This includes this red bin, okay, or red shelves, okay. It has to be labeled. The shelf has to be labeled that this shelf, it contains high alert medication, or closed cabinets, and it has to be separated and designated area. It can't be mixed with other medication, and it has to have appropriate labeling. The labeling, it can be on the container itself, on the vial itself, or the strip itself. It is not, it can be, it has to be in the package, okay. It has to be the area at which it is being stored. It has also to be labeled as high alert medication. Here is an example about the labeling. If you can see here, the label of high alert medication, it is in the product package itself. Here it is in the container, the red bin. Here in the storage shelf, it is here in the shelf, it's written that this shelf contains, it gives an indication that it contains high alert medication. And here, even if you have a complete box of ampoules, potassium chloride, for example, in the box outside, you will put the label, and in every individual vial or ampoules, you have to put this tag as well. So this is the storage and labeling of high alert medication. As long as prescribing of high alert medication is concerned, first of all, there is no verbal orders to be obtained with regard to high alert medication. This is completely discouraged, except that if the doctor is in emergency, he's resuscitating a patient, he needs, for example, something which is not there in the crash card, this can happen, but otherwise it has to be discouraged. You have to be careful when using the abbreviation. Try to use the approved abbreviation, as we said, for example, units, U and units, and so on. And it is not only it is the responsibility of you as a pharmacist to, for example, in a nice way, to correct any mistakes in the medication record that's written by the prescriber. And also, we said we have to avoid the trailing zero when prescribing, that is 5.0. And also a high alert medication label, it has to be there in the drug itself, the container, and it has to be also in the MAR. In the MAR, we know that the medication administration record is, if you find the list of the medication, the dose, the route, and then there is some blanks for the nurses when they administer, they have to sign on it. So in every order of high alert medication, a high alert medication label has to be fixed adjacent to them in the MAR. And then in the preparation and dispensing, most probably who will prepare high alert medications are the pharmacists. We are the one who we are accountable about this. There should be double checking while you are dispensing, okay, double checking between you and the nurse, okay. And also, if the patient, okay, if it is an inpatient, then the nurses will be taking care of it. But if a patient is being discharged on high alert medications such as warfarin or insulin or any other high alert medications, there should be a label as high alert medication. The patient or the family has to be educated about this, and they have to be counseled, and you have to make sure that they have enough knowledge about these medications and how to use them appropriately. Lastly, we have got the administration. As I said, the administration while the patient is in the hospital, it will be by the nurses, and there should be independent double check of all high alert medication and continuous intravenous infusion. Okay. This double check is recorded. It is recorded and signed in the medication administration record. Okay, and you have also to make sure if the patient is using, for example, anticoagulant or antiarrhythmic, and for any reason he's being transferred from one unit to another, then we have to make sure that the caregiver are aware about these medications. Okay, and we have to endorse it clearly to wherever the ward he's going to. For example, if he was in the medical ward and he's going to the emergency department, okay, I have to, it has to be clearly there that this patient is using anticoagulant, and that is all to avoid any errors, okay, and to avoid any gap in transferring information between healthcare providers in the different units. So that's all about high alert medications. It was just something which is very simple, very quick, okay, and it is one of the important topics that every pharmacist has to be aware about it, and it's encountered a lot in the hospitals. Thank you very much. I hope that was an informative presentation enough, and inshallah seeing you soon in other workshops or small lectures. Thank you very much.